when we read, we talk about calibration, rate and rhythm at the first step. Second step, we talk about the P wave and the PR interval. Third step, we talk about the QRS complex, in which we look at the QRS morphology, the QRS duration, and the QRS voltage, and the QRS axis. 4 things in the QRS complex. The next that we look at is the QT interval, and then we talk about the ST T wave complex and the U wave. So please remember these 6, they occur in sequence. That is how you are supposed to record and read the ECG or report an ECG. Whenever somebody asks you what is there in the ECG, all these 6 things need to be there. What is the calibration? What is the rate? What is the rhythm? How are the P waves and the PR interval? How is the QRS complex? What is the QT interval like? The ST-T wave complex and the U wave. Let's move on from here. Let's talk about the calibration, rate and rhythm. So when you look at an ECG, at the beginning of every ECG, what happens that the machine gives a pulse of 1 millivolt. It sends impulses of 1 millivolt. So 1 millivolt should record 1 large square on the ECG. So each 1 millivolt is about 10 mm. So you should see a recording of 1 millivolt. That means 10 mm rise should be there in the calibrating impulse. Now this impulse is given for 0.2 seconds. If you remember, 1 large square was 0.2 seconds. So the height of this calibrating wave will be 1 millivolt, 10 mm, and the length of this would be 0.2 seconds. So that it's important to see this calibration, because if this calibration is disturbed, then you will not be able to see the voltages and the periods in the ECG to interpret it appropriately. That's why it is very important to look at the calibration and make sure that the calibration is correctly done. Otherwise, your interpretation of the ECG findings will be faulted. How do you calculate the heart rate? Not very difficult, not rocket science. You have a magic number, 1500. You divide it by the number of small squares in 1 RR interval. So how many small squares are there between 2 R waves? That is 1 RR interval. You divide that by 1500. So if you have, let's say, 20 small squares in between 2 RRs, and if you divide 1500 by 20, you will get the heart rate of that ECG. And when you do this, this will go cancel, and you will get equal to 75. So if there are 20 small squares, your heart rate is 75. If you want to get a little more crude, if you have the big squares, now another poll will be coming up on your question. What number would you need to divide the number of big squares between an RR interval to get the same answer? The poll is being launched now. What number divided by the number of large squares between 1 RR interval will give you the heart rate? Remember, when you count the small squares, the number is 1500. 1500 by the number of small squares. But if you are counting the number of big squares, what number would you need to divide the number of big squares with? So almost all of you got that right. Practically 90%, more than 90% got it right. Obviously, because एक बड़े square में 5 छोटे square होते हैं. So 1500 को 5 से divide करोगे तो you will get the magic number, and that is 300. So if you count this large squares, you need to divide 300 by the number of big squares. Normal heart rate is 60 to 100. Less than 60 is bradycardia. More than 100 is tachycardia. Nothing very great in that. So what is the heart rate in this particular ECG? If you look at this ECG, count the number of squares between the 2 RR intervals. So if this is the R wave for this particular complex, and this is the R wave for this particular complex, you have approximately 1, 2, 3, 4, 5, and practically 6 big squares, and you divide 300 by 6, and you will get the answer. So the answer is 50. If you go to the next slide, what do you think is the heart rate here? Again, count the number of big squares between two RR intervals. Got 1, 2, 3, and 4. So you've got 4 big squares between two R waves. And so 300 by 4 should give you the answer for this, which will be approximately 75. But you need to remember and see very carefully that the rhythm of the QRS complexes should be regular to apply this formula. If the rhythm is not regular, then you can't apply this formula. To look at the rhythm is called sinus. If it is originating from SA node, you should have a P wave before every QRS complex. So every QRS complex should be preceded by a P wave, and the P wave should be in the same direction of positivity as the QRS complex. It's if all these three criteria are satisfied, you say that you have a sinus rhythm. So what do you think is the rhythm in this? Yes, this is a normal rhythm. This is normal sinus rhythm. You have a P wave every time you look at lead 2, mostly to make your analysis. You have a P wave before every QRS complex. The P wave is in the same direction as the QRS complex, and there is equal distance between R and R intervals, and it's every time the same thing. Let's talk more about P wave and PR interval. So the P wave, a normal P wave, should have about 2.5 squares either way. That means horizontally and vertically. So if it's within 2.5 squares, then it is normal. That means it is less than 2.5 millimeters in the upward direction in the vertical axis. It's 2.5 millivolts, and it's less than 0.12 seconds in its length. That comes to about roughly 2.5 squares either side. A normal P wave is always positive in lead 2, and it is always negative in AVR, because we said it AVR is a mirror lead most of the time. And retrograde P waves is when you get P which is negative. So if you find a negative P, so you get a ECG tracing something like this, and you get a, so the drawing with the computer cursor is difficult. If this is the P and it is inverted, then mostly that means that your pacemaker is an ectopic pacemaker, and the impulse is traveling in the reverse direction from the AV node towards the SA node. So if this was the SA node here and this was the AV node here, in normal circumstances, the impulse would have traveled like this, and we would have got a positive vector giving a positive P wave. Whereas if it's traveling in the reverse direction, giving rise to a negative vector, then it will give rise to an inverted P wave, and we say it is the impulse is coming from an ectopic pacemaker. So the genesis of P wave, again to remind you, is because of the transmission of impulse from the SA node to the AV node. So P wave can be abnormal if it has got an abnormal rhythm, if it has got an abnormal morphology. In terms of morphology, you need to see whether it is uniform. That means each P wave has got the same shape. You might find that one P wave is big, like my drawings, and some P waves are flatter, some P waves are higher. That means there are impulses coming from different areas. They are not coming from the same area. If it comes from the same area, all P waves will be looking alike. If they are not looking alike, that means the impulses are coming from different places. You need to see whether all of them are upright. We just talked what happens if they are inverted. You need to look at the size of the P waves. If the size of the P wave is increased in the vertical direction, that means it is more than 2.5, the number that we were talking about, then what we have is what is called the P pulmonale, which is a representation of the right atrial overload. However, if the P wave is stretched out in the time, that means it's longer, and you find that the P wave is biphasic, उसमें negative component भी है और उसमें positive component भी है, with the negative component which is more than the positive component, then we find that this is largely due to left atrial overload. तो लेफ्ट एट्रियल ओवरलोड से लंबी हो जाएगी, राइट एट्रियल ओवरलोड से ऊंची हो जाएगी, and this in this state is called the P mitral. Again, very common questions: what is P pulmonale and what is P mitral? So this is another graphic recording. What happens? So here is a normal P wave in lead 2. Here is the right atrial overload in which you get a elongated or a higher P wave which has gone higher. And here you have got a left atrial enlargement in which you get a longer or a much longer P wave in which you have a negative component or a notching or a in V1 you have a negative and a positive component. The negative is more than the positive area, and in the lead 2 you have a notched P wave. If you have both, then it will look something like this. So this is a narrow complex. You have QRS, which is looks narrow, it's not broadened. And if you look at the P waves here, you have the P waves which are inverted. You look carefully in V5, these are inverted. In lead 2, you have inverted P waves. All P waves are upside down. So that means it's coming from a pacemaker, which is not normal. That's an ectopic atrial rhythm. A PR interval, next we talked, what was the PR interval? The PR interval is from the beginning of the P wave and until the start of the QRS complex. So it starts at the beginning of the P wave and goes on till the onset of the R wave. So first negative deflection would be the Q wave, and it will go up till the peak of the R wave. So it ends at the peak of the R wave and starts at the beginning of the P wave. That's the PR interval. The normal length of this should be 0.1 to 0.2 seconds. If you remember, 0.2 seconds is also the length of one big square. So a normal PR interval should finish in one big square. A short PR interval is when we say it is less than 0.12 seconds, and a long PR interval is when it is longer than 0.2 seconds. If it is less than 0.12 seconds, an important consideration that we need to think about is the WPW syndrome. We will see more, or you can read more about what it is. That's one of the components. It's not sufficient, but it is necessary to call it a WPW syndrome. When it is longer than 0.2 seconds, we have the first degree heart block. So if you find that all the P waves are there, all the QRS complexes are there, but the PR intervals are prolonged beyond 0.2 seconds, then we say this is the first degree heart block. The genesis of the PR interval, as we earlier said, it is because of the delay of the impulse at the AV node. So let's see this ECG, what's going on here. If you can see, it shows basically a rhythm which is irregular. You can't make out any clear P waves. If you look at lead 2 here, you can't distinctly make out any P wave, and there is an irregular recording. This is one of the most common ECGs that you will get in your exam as an undergraduate student. When you can't see the P wave and the rhythm is irregular, the heart rate is usually high, then the answer is atrial fibrillation. This is another atrial fibrillation, but the difference from the previous ECG is that here there are no P waves, but the heart rate is stretched, it's slow. So in atrial fibrillation, this is also atrial fibrillation, but with a slower heart rate. It's rare to get that kind of an ECG. You will not get that kind of an ECG in most of the times, even in your exams. You will have a higher heart rate unless the patient has been controlled to a great extent.